Welcome to our deep dive. You ready to explore the respiratory system?
I'm ready. Let's breathe it in.
Okay, so we've got all these fascinating materials, nursing course notes, exam questions, and even this super colorful chart of inhaler medications.
It's going to be amazing.
By the time we're done with this deep dive, you'll practically be a nursing student when it comes to respiratory care.
That's the goal.
Okay, so let's start with the basics, shall we? Respiratory System 101.
Yeah,
So breathing through your nose, we all know it's better than mouth breathing.
absolutely. It filters the air, humidifies it much better for your lungs.
But here's something I've always wondered. Why does the right lung seem so prone to trouble? Like if you inhale food accidentally.
Oh, that's a good question.
Hmm.
It all comes down to anatomy. The right bronchus, that tube leading to the right lung, it's shorter and straighter than the left one.
So it's like a direct route for anything you inhale to take a wrong turn.
Exactly, a superhighway straight to the right lung.
Makes you want to chew your food really carefully.
You got it. Now, these nursing notes, they dive into something called lung mechanics.
Oh yeah, that sounds a bit technical.
It is, but it's super important. It's all about ventilation, elastic recoil compliance, and diffusion.
Okay, so ventilation, that's basically just breathing in and out, right?
That's it, the simple act of breathing.
And elastic recoil. That's the lungs springing back to their original shape after each breath.
Exactly. Think of it like a rubber band snapping back into place.
Okay, I get that. What about compliance? The notes say it decreases with age and conditions like emphysema.
Imagine you're trying to inflate two balloons, one brand new and one super old and stiff. The new one inflates easily, right?
Yeah, way easier.
But the old one takes way more effort. That's kind of like compliance. It's a measure of how easily your lungs stretch.
So high compliance, good stretchy lungs. Low compliance, not so stretchy.
Exactly. And then we have diffusion.
Which is all about gases moving around, right? Oxygen and carbon dioxide?
Precisely. Think of a really crowded room where people need to move around. Diffusion is how oxygen gets from those tiny air sacs in your lungs into your bloodstream, and how carbon dioxide moves out.
Okay, so it's like a two-way street in the lungs.
That's a great way to put it. And speaking of things moving in and out, these nursing notes also mention different lung volumes.
Oh yeah, I remember those. Tidal volume, inspiratory reserve, expiratory reserve. There's a lot to keep straight.
It is, but let's break it down. Your tidal volume, that's the air you breathe in and out normally with each breath.
Okay, got it.
But you can breathe in even more deeply if you need to.
Yeah.
That extra air you can pull in, that's your inspiratory reserve volume.
Makes sense. And you can also force more air out. That's expiratory reserve.
Exactly. And then there's the air that always stays in your lungs.
The residual volume.
Yes, otherwise your lungs would collapse.
Okay, that makes sense. Now, these notes also talk about something called ABGs.
Arterial blood gases. They're taken from an artery to check your oxygen levels and the acid-base balance of your blood.
Right, and I remember reading that even tiny changes in blood pH can have big consequences for the body.
Absolutely. It needs to stay within a very narrow range. And speaking of things that can have consequences, let's talk about breath sounds.
You mean the difference between normal breathing and those weird sounds like wheezing and crackles?
Exactly. Those abnormal sounds can be real red flags. The notes even describe a pleural friction rub as sounding like sandpaper.
Ouch, I bet that's not comfortable.
Not at all. It happens when the tissues around the lungs are inflamed and rubbed together.
Okay, so let's say someone is showing signs of respiratory distress. What are some immediate nursing actions?
First things first, sit them up. Help open up that chest. Then carefully check their oxygen levels with a pulse oximeter.
And encourage them to take deep breaths.
Yes, deep and slow breaths. And if that's not enough,
Then they might need oxygen therapy, right?
you got it. And it's crucial to stay with them and call for help if their condition gets worse.
Makes sense. Okay, let's talk about some specific conditions. Now, these notes, they dive deep into asthma. And it's a condition that affects a shocking number of Canadians, 4.6 million.
Wow, that's a lot of people.
It's like the entire population of Manitoba.
It's truly widespread, and it just emphasizes the need for greater awareness and support for people with asthma.
Absolutely. So asthma is a chronic inflammatory disease that affects the airways, right?
Exactly. That inflammation causes the airways to become obstructed, making it hard to breathe, and the severity it can fluctuate, which leads to those unpredictable asthma attacks.
And those attacks, they can be triggered by so many things. Allergens, smoke, even exercise.
Right, even exercise. It's called exercise-induced bronchospasm. The notes explain that in some people, even something as simple as exercise can trigger an immune response in the airways, leading to those classic asthma symptoms.
So what's actually happening inside the airways during an attack?
It's like a chain reaction, exposure to a trigger, like let's say pollen sets off this immune response. And this triggers the release of inflammatory mediators.
Those are chemicals, right?
Yes, and they cause the muscles around the airways to constrict, making them narrower.
And then to make matters worse, there's increased mucus production and the lining of the airway starts to swell.
Exactly. It's like a traffic jam in there. So no wonder people feel like they can't breathe.
So how do healthcare providers diagnose asthma?
Well, the detailed patient history is crucial. They'll want to understand your symptoms and identify any potential triggers. And then there's a pulmonary function test called spirometry.
Oh, I remember those. You blow into a tube as hard as you can.
That's the one. And an asthma spirometry helps identify reversible airway obstruction. Basically, after inhaling a bronchodilator medication, lung function significantly improves.
So that's how they confirm the diagnosis.
Exactly. And that brings us to managing asthma. The good news is there are so many things we can do to help people live full lives despite having asthma.
That's reassuring. What are some key strategies?
Well, first and foremost, minimizing exposure to those triggers we talked about. If dust mites are an issue, taking steps to reduce them in your home is essential.
Makes sense.
Yeah.
What about medication?
Medication is a cornerstone of asthma management. And actually, the notes include this really cool, colorful chart outlining all the different inhaler medications. There are two main types, controllers and relievers.
So controllers, those are for preventing attacks.
Exactly. They help reduce inflammation in the airways and prevent those attacks from happening in the first place.
And relievers are for when symptoms flare up.
Exactly. They're what you reach for when you're having an attack. A common one is Ventolin, also known as salbutamol. It relaxes the muscles around those airways, making it easier to breathe.
Okay, so managing asthma is all about teamwork.
Absolutely. It's the healthcare team, the patient and their family all working together. And continuous monitoring is key because every case is different. What works for one person might not work for another.
All right, so we've covered a lot about asthma. Now let's move on to another common condition, COPD.
COPD, chronic obstructive pulmonary disease. It's a big one. It's preventable and progressive, meaning it gets worse over time.
And it affects over 2 million Canadians. And the notes actually point out that the prevalence is even higher among Indigenous populations in Canada, really highlighting the impact of social determinants of health on respiratory health.
That's such an important point. Access to healthcare, environmental factors, socioeconomic conditions, all of these things contribute to a higher risk of developing COPD.
So what exactly defines COPD?
The main characteristic is persistent airflow limitation. It's hard to get air in and out of the lungs.
And that leads to symptoms like shortness of breath fatigue, chest discomfort, and a chronic cough.
Exactly. And sadly, it can lead to some serious complications like right-sided heart failure and even respiratory failure if it's not managed well.
Okay, let's talk about what causes COPD. Smoking is a major culprit, right?
Absolutely. Smoking damages the lungs and increases the risk of COPD significantly. But there are other causes too, like exposure to certain dusts and chemicals in the workplace.
And the notes also mentioned a genetic component.
Yes, some individuals are genetically predisposed to COPD, making them more susceptible even with limited exposure to other risk factors.
So it's a combination of factors.
Exactly. Now, the notes break down COPD into two main types, chronic bronchitis and emphysema.
Okay, so what's the difference?
Well, think of chronic bronchitis as constantly irritated airways. The lining is inflamed, leading to that classic chronic cough with mucus. And over time, this inflammation and mucus buildup can damage and narrow the airways, making breathing even more difficult.
So it's like a vicious cycle. What about emphysema?
Emphysema focuses on the alveoli, those tiny air sacs where gas exchange occurs. In emphysema, those air sacs are destroyed. They lose their elasticity and their ability to expand and contract.
So they can't effectively exchange oxygen and carbon dioxide?
Exactly. And as more alveoli are destroyed, breathing becomes incredibly difficult. This often leads to what's called a barrel chest appearance because the lungs become hyperinflated, making it hard to exhale completely.
It sounds like a really debilitating condition. How is COPD diagnosed?
Spirometry, that breathing test we talked about earlier, is key. It helps assess the severity of airflow limitation and categorize COPD into different stages, from mild to very severe.
And that staging helps guide treatment decisions.
Absolutely. Now let's shift gears a little bit and talk about the nursing perspective on COPD. What are some of the main concerns when caring for a patient with this condition?
Well, the notes emphasize promoting airway clearance, helping them get rid of that excess mucus. Improving gas exchange is also crucial so they can breathe easier.
Exactly. And we can't forget about the risk of infections.
Right, because their lungs are already compromised.
Precisely. Another concern is managing activity intolerance. Even simple tasks can be exhausting for someone with COPD. And then there's the emotional impact of living with a chronic illness.
Absolutely. Supporting their mental health and coping mechanisms is so important.
You got it. The notes also mention addressing nutritional concerns.
Which makes sense because fatigue and shortness of breath can make it hard to eat enough.
Exactly. Now, in terms of medication for COPD, we see both controllers and relievers, again, just like with asthma.
And this handy COPD medication chart shows all sorts of different types of bronchodilators which open up the airways. There are even combination inhalers that include both bronchodilators and anti-inflammatory medications.
Right, and the choice depends on the individual patient's needs and the severity of their COPD. Now, there's one more crucial aspect we need to discuss regarding COPD, the potential complications.
Because COPD can lead to some pretty serious issues.
Absolutely.
Right.
One of the most common complications is something called an acute exacerbation of COPD, or AECOPD. It's basically a sudden worsening of the disease, and respiratory infections are often the trigger.
So something as simple as a cold or the flu can really set them back.
Unfortunately, yes. But allergens, irritants, even cold air can trigger AECOPD. The notes emphasize recognizing the signs and symptoms early.
So what should we be looking for?
Things like increased shortness of breath, coughing, wheezing, changes in their sputum production, those are all red flags.
And if someone is experiencing AECOPD, what are the key nursing interventions?
First, a thorough respiratory assessment, checking their oxygen levels, listening to their lungs. Depending on the severity, they might need additional medications like bronchodilators, steroids, or even antibiotics if there is a suspected infection.
And vaccinations are really important too.
Absolutely. Preventing those respiratory infections in the first place is a key part of managing COPD.
Okay, so AECOPD is one complication. Are there others we should be aware of?
Yes, unfortunately. One is carbon dioxide narcosis.
The notes describe it as a buildup of carbon dioxide in the bloodstream. It happens when the lungs can't effectively get rid of the carbon dioxide.
Right, and this can lead to a depressed level of consciousness. It can be very dangerous.
So what are some early warning signs?
Things like headaches, mild shortness of breath, rapid breathing confusion, or drowsiness can all be early indicators.
And as it progresses, it can lead to a decreased level of consciousness delirium and even a decreased drive to breathe.
Exactly. That's why recognizing those early signs is so crucial. The notes mention that managing the underlying AE-COPD and carefully adjusting oxygen therapy are key to treatment.
So giving too much oxygen could actually worsen things.
In some cases, yes. It's a complex process, but it highlights the need for careful monitoring and personalized care.
We've covered AECOPD and carbon dioxide narcosis. The notes also mention cor pulmonale as a serious complication of COPD.
Cor pulmonale is right-sided heart failure, and it occurs because of pulmonary hypertension, high blood pressure in the arteries of the lungs.
So all that pressure strains the right side of the heart, and eventually it weakens and can't pump effectively.
Exactly. And cor pulmonale is considered a late manifestation of COPD, meaning it tends to develop after years of living with the disease.
What are the signs and symptoms of cor pulmonale?
They're similar to right-sided heart failure in general. You might see swelling in the legs and ankles, distended neck veins, even fluid buildup in the abdomen.
It sounds like cor pulmonale significantly impacts a person's quality of life.
Absolutely. And it can be very challenging to manage.
Okay, so we've covered 3 serious complications of COPD, AECOPD, carbon dioxide narcosis, and cor pulmonale. Are there any others?
Yes, one more I want to mention is polycythemia.
Polycythemia, what's that?
It's a condition where the body produces too many red blood cells.
And why does that happen in people with COPD?
It's the body's attempt to compensate for chronic hypoxemia, low oxygen levels in the blood. Because the body is constantly starved for oxygen, it tries to make up for it by churning out more red blood cells to carry that oxygen.
But more red blood cells means more oxygen. Shouldn't that be a good thing?
Not necessarily. Having too many red blood cells can actually thicken the blood, making it more prone to clotting.
So that increases the risk of blood clots or thrombosis.
Exactly.
Yeah.
And those clots can travel to the lungs, heart, or brain, causing serious problems like pulmonary embolism, heart attack, or stroke.
Okay, so polycythemia is definitely something to keep in mind with COPD patients.
It really highlights the complexity of this disease and the importance of monitoring for these potentially life-threatening complications.
Well, we've covered a lot of heavy stuff with COPD. Let's shift gears to something a little lighter.
All right, how about obstructive sleep apnea, or OSA? It's more than just loud snoring. It's a serious sleep disorder.
The notes say it involves repeated pauses in breathing during sleep.
Exactly. And those pauses called apneas, they can last for 10 seconds or even longer.
Wow, that sounds scary. How common is this?
It affects over 6% of Canadians, which is a surprisingly high number.
So besides snoring, what are some signs and symptoms of OSA?
Excessive daytime sleepiness is a big one. People with OSA often wake up feeling unrefreshed no matter how much sleep they get.
And the notes also mention morning headaches, irritability, even personality changes.
That's right. OSA disrupts sleep, which can have a wide range of effects on mood and behavior.
Okay, so what causes these breathing pauses during sleep?
It all comes down to muscle relaxation. When you fall asleep, the muscles in your throat relax. And for people with OSA, this relaxation allows the tongue and soft palate to fall back and obstruct the airway.
So it's like a physical blockage of airflow.
Exactly. And if OSA is left untreated, it can have some pretty serious consequences for your health.
Like what?
It's linked to an increased risk of high blood pressure, heart rhythm problems, stroke, even heart failure.
Wow, that's definitely not something to ignore. How is OSA diagnosed?
The gold standard is a sleep study called polysomnography. It involves spending the night in a sleep lab hooked up to all these monitors that track your brain waves, heart rate, breathing patterns, and oxygen levels.
Sounds like a pretty comprehensive test. What are some treatment options for OSA?
Well, lifestyle changes are often the first line of defense. Things like losing weight if you're overweight, or obese, quitting smoking, and avoiding alcohol before bed.
And for some people, simply changing their sleep position can help.
Exactly. Sleeping on your side instead of your back can make a big difference for some individuals.
The notes also talk about CPAP machines and oral appliances. What are those?
A CPAP machine delivers continuous positive airway pressure. It's like a gentle air splint that keeps the airway from collapsing. And oral appliances are custom-fit devices that help reposition the jaw and tongue to keep the airway open during sleep.
And in some cases, surgery might be an option?
Yes, if there's a structural issue in the nose or throat contributing to OSA, surgery can sometimes correct it.
So the best approach really depends on the individual patient. What about OSA and hospitalization? Are there any special considerations?
Absolutely. If a patient uses CPAP at home, it's crucial that they continue to use it in the hospital. We don't want them to experience those breathing pauses during sleep in a hospital setting. And we need to be extra careful with certain medications like opioid painkillers and sedatives, which can worsen breathing problems in people with OSA.
Makes sense.
Yeah.
And careful monitoring after surgery is important too, right?
Absolutely. Anesthesia can sometimes worsen OSA, so it's crucial to watch for any breathing difficulties after surgery and be prepared to provide additional support like oxygen or even mechanical ventilation if needed.
Well, we've certainly covered a lot of ground in this deep dive, from basic lung anatomy and function to asthma, COPD, and OSA. It's been quite a journey.
We've barely scratched the surface, but you've done an amazing job absorbing all this information.
Thanks. It's fascinating how interconnected it all is. We can't really understand these respiratory conditions without understanding how they affect the entire body.
Exactly. It highlights the importance of a holistic approach to care. We need to consider the whole person, their lifestyle, their environment, their emotional well-being when addressing respiratory health.
Well, this is just part one of our deep dive. We'll be back soon with part two, where we'll explore even more about respiratory care.
We'll dive into some real-life scenarios and explore how this knowledge can empower you to make informed decisions about your own health and the health of your loved ones.
Until then, keep breathing and stay curious. Welcome back to our respiratory journey. We covered so much ground in part one, all that anatomy and those fascinating conditions.
Yeah, asthma, COPD, OSA. It's amazing how much there is to learn about something we do every single minute.
Absolutely. And you know, those nursing exam questions you provided, they really put our knowledge to the test.
They did. They really made me think critically about all the different aspects of respiratory care.
It's like a whole new way of looking at breathing.
It is. And you know, as I was reviewing those questions, something interesting popped up about nasal breathing.
Oh yeah, the benefits of breathing through your nose. We know it's better than mouth breathing. It acts as a natural filter and humidifier for the air we breathe.
Exactly. Mouth breathing, it kind of bypasses those important functions and can lead to dry, irritated airways.
And that can increase the risk of infections.
Exactly. It's like leaving the front door to your house wide open.
I like that analogy. So nose breathing for the win. Those exam questions also touched on the diaphragm.
Ah, the diaphragm. The powerhouse of respiration.
I remember learning that it's this big dome-shaped muscle that plays a crucial role in breathing.
It does. When you breathe in, the diaphragm contracts and flattens, increasing the volume of your chest cavity.
And that creates a vacuum that sucks air into the lungs.
Exactly. It's like a natural bellows Then when you breathe out, the diaphragm relaxes, pushing the air back out.
So it's constantly working even when we're not consciously thinking about it.
That's right. It's always there working behind the scenes to keep us breathing. Now, those exam questions, they even got into some pretty specific anatomy, like the carina.
The carina. What's that?
It's that ridge of cartilage at the bottom of the trachea, right where it branches into the two bronchi.
Oh, right. And it's super sensitive. The note said that even a light touch can trigger a coughing fit.
It's like a built-in security system for your lungs, preventing foreign objects from getting in.
Okay, that makes sense. Those exam questions also had me thinking about lung volumes again. You know, tidal volume, inspiratory reserve.
Expiratory
reserve. I always get those confused.
I understand it could be a lot to keep straight, but think of it like a measuring cup.
Okay, I like that.
So your tidal volume, that's the normal amount of air you breathe in and out with each breath, but you can breathe in even more deeply if you need to.
Right, that's the inspiratory reserve volume.
Exactly. And you can also force more air out. That's your expiratory reserve volume.
Okay, so it's like our lungs have these hidden reserves that we can tap into when we need to.
Exactly. Pulmonary function tests like spirometry, they measure all these different volumes to assess how well your lungs are working.
So it's not just about how much air you can blow out, it's about all these different components.
Exactly. It's a comprehensive look at lung function. Now, speaking of those exam questions, the ones about asthma were really interesting.
Yeah, I was surprised to learn that even exercise can trigger an attack in some people. It seems counterintuitive.
It does, right?
Mm-hmm.
But it highlights the complexity of this condition. Remember the early phase of an asthma attack, that bronchospasm and airway narrowing happens rapidly, usually peaking within 30 to 60 minutes after exposure to a trigger.
And then there's that delayed reaction, the late phase response.
Exactly. That involves more inflammation and can drag on for hours or even days.
And what's even more interesting is that the late phase response can actually make someone more sensitive to triggers in the future.
It can create this vicious cycle. And speaking of triggers, there was a question about dust mites and their role in asthma.
Dust mites are a classic trigger for so many people.
Mm-hmm.
They thrive in warm, humid environments, so controlling dust mites in the home is crucial.
Absolutely, especially for people with asthma. Now, we also talked about breath sounds and how important they are in assessing respiratory health.
Right. I remember reading about fine crackles and how they can be a sign of fluid in the lungs, like in pulmonary edema.
Yes, those fine crackles sound like tiny bubbles popping open. And pulmonary edema, that fluid buildup in the lungs, can be caused by various things, including heart failure.
So hearing those crackles should always prompt further investigation to figure out the underlying cause.
Absolutely. Early detection is key for managing any respiratory condition. Now, those exam questions also got into COPD and what can cause those sudden flare-ups or acute exacerbations.
ACOPD. We talked about how respiratory infections are often the trigger.
Exactly. Things like the common cold, the flu, or pneumonia. They can really wreak havoc on lungs that are already compromised.
And the notes really emphasize the importance of recognizing the signs of respiratory distress early on.
Yes. Things like cyanosis, that bluish discoloration of the skin, and the use of accessory muscles, those muscles in the neck and chest that we don't normally use for breathing.
Right, when someone's struggling to breathe, they start using those extra muscles to help pull air in.
Exactly. And the tripod position, where someone leans forward, supporting themselves with their hands, that's another classic sign.
It's like their body is instinctively trying to make it easier to breathe.
Exactly. Now, there was also a question about wheezing in asthma and what indicates a severe obstruction.
Wheezing is that high-pitched whistling sound, right?
Yes, it's caused by air trying to squeeze through narrowed airways. But here's the thing, wheezing isn't always a reliable indicator of severity.
So someone could have mild wheezing or even no wheezing with severe obstruction.
Exactly. And that silent chest is much more concerning. It can indicate that there's very little air movement, which is a medical emergency.
Okay, that's definitely something to watch out for.
Absolutely. Always listen carefully to those breath sounds and consider the whole clinical picture. Now, those exam questions also touched on risk factors for asthma. We know family history plays a role, but what about obesity?
Obesity is increasingly recognized as a significant risk factor for asthma.
It is. It can contribute to inflammation in the body, making the airways more sensitive and reactive.
That makes sense.
Yeah.
What about cholesterol levels?
High cholesterol, while a major risk factor for heart disease, isn't directly linked to asthma.
Okay, good to know. There was also a question about oxygen levels and that SpO2 measurement we see on those fingertip pulse oximeters.
Right. SpO2 stands for arterial oxygen saturation. In a healthy person, it should ideally be between 95 and 100%.
So anything below that range could indicate a problem with oxygen getting into the bloodstream.
Exactly. It could be a sign of a lung issue or even a problem with circulation.
Okay, so it's an important number to keep an eye on. And what about those nursing interventions for respiratory distress?
Well, elevating the head of the bed can help.
I remember reading that. It helps open up the chest and improve lung expansion.
Exactly. And if someone's oxygen levels are low, we might need to increase the flow rate of supplemental oxygen.
It's amazing how simple interventions can sometimes make a big difference.
It is. And, those exam questions even got into some pretty specific anatomical details, like the parietal pleura.
The parietal pleura, that's one of the membranes surrounding the lungs.
Exactly. And what's interesting about the parietal pleura is that it's packed with nerve endings, making it very sensitive to pain.
So that's why conditions like pleurisy, where the pleura is inflamed, can be so painful.
Precisely. It's like having an irritated lining rubbing against your lungs with every breath.
Ouch. And then we touched on that late phase response in asthma again.
Right, that delayed reaction characterized by inflammation. It's often what makes people more sensitive to triggers in the future.
It's like their airways are on high alert.
Exactly. And those exam questions, they really tested our knowledge of some key terms like compliance.
Compliance. How easily the lungs inflate.
Yes, and stridor, that high-pitched crowing sound we hear with upper airway obstruction.
Those were definitely some challenging questions. But they really forced us to think critically.
They did. They even asked about hypercapnia in COPD patients.
Hypercapnia. High levels of carbon dioxide in the blood.
Right. And since COPD makes it hard to exhale completely, CO2 can build up in the bloodstream.
Another question highlighted the fact that cold, dry air can be a trigger for asthma attacks.
Absolutely. It can irritate the airways and lead to bronchospasm. Just another reason why managing triggers is crucial.
And we learned that while oxygen therapy is essential in certain situations, it's not always the first-line treatment for COPD.
Exactly. In some cases, giving too much oxygen can actually worsen carbon dioxide retention in those patients.
So it's a delicate balance. It really highlights the need for careful monitoring and personalized care.
You got it. Now, there was a question about some common triggers for asthma besides dust mites.
There's a long list: pollen mold, pet dander, cockroaches, smoke, strong odors, even stress and anxiety can trigger asthma symptoms.
It's amazing how many things can set off those airways.
And we also talked about the key components of effective asthma management.
Right. Regular use of those inhaled corticosteroids to control inflammation, being diligent about avoiding triggers, and having a personalized asthma action plan.
It's all about being proactive.
It is. And those exam questions also touched on the more serious complications of COPD.
Right. We discussed Cormonell carbon dioxide narcosis and those challenging select all that apply questions about respiratory distress.
Those were tough, but they really helped solidify our understanding of those key signs and symptoms, like nasal flaring, grunting, the tripod position.
And we also explored the characteristics of chronic bronchitis, that chronic productive cough, shortness of breath with exertion, and even cyanosis.
Those exam questions, they really pack in a lot of information.
I do. They challenge you to think like a nurse and apply your knowledge to real-life situations.
It's not just about memorizing facts. It's about understanding how those facts translate into caring for patients.
Okay, I'm ready for the next challenge. What else do we have in store?
Well, we've covered a lot of the nursing-focused questions. Let's shift gears a little bit and explore some broader aspects of respiratory health and see how it all connects back to what we've learned so far.
Sounds great. I'm ready to delve deeper into this fascinating world of breathing. Those nursing exam questions really pushed us to think like nurses.
They did, didn't they? It's amazing how much we've learned from these notes and charts and exam questions.
It is.
Yeah.
It's like we've unlocked a whole new level of understanding about the respiratory system.
We have. And, as we've been exploring all these different conditions, asthma, COPD, OSA, one thing that's really struck me is how interconnected it all is.
What do you mean?
Well, we tend to think about the respiratory system as this isolated unit, just the lungs and airways.
Right, like it's separate from the rest of the body.
Exactly. But it's so much more than that. It impacts every single part of us.
That's true. We've seen how COPD can affect the heart, leading to cor pulmonale, and how OSA can disrupt sleep and impact mental health.
It's a powerful reminder that we can't just focus on the lungs in isolation. We need a more holistic approach to care.
Absolutely. We need to consider the whole person, their lifestyle environment, and even their emotional well-being.
Exactly. Speaking of emotional well-being, I remember reading something fascinating in those nursing notes about the connection between breathing and stress.
Oh yeah, I remember that too. It's like when we're stressed or anxious, our breathing changes. We take these short, shallow breaths.
It's like we're holding our breath without even realizing it.
Exactly. And then when we're relaxed and calm, our breathing naturally slows down and deepens.
It's amazing how our breath mirrors our emotional state.
So there's this clear link between our breathing patterns and how we're feeling.
And what's even more fascinating is that this connection goes both ways.
What do you mean?
I mean, we can actually influence our emotional state by changing how we breathe.
That's what all those deep breathing exercises are about, right? People swear by them for managing stress.
Exactly. By consciously slowing down and deepening our breath, we can actually calm our nervous system and reduce those feelings of anxiety.
It's like we have this built-in tool for stress management, and we often don't even realize it.
It makes you appreciate the power of breath on a whole new level.
This deep dive has been incredible. We've learned so much from those nursing notes and exam questions.
We have from basic lung anatomy to all those complex conditions.
Asthma, COPD, OSA, and those tricky ABGs.
And we've seen firsthand how those nursing interventions can make a real difference in respiratory care.
It's been quite a journey. And we've come to realize that breathing, it's so much more than just taking in oxygen and releasing carbon dioxide.
It's a vital link between our physical and emotional well-being.
A link that we can learn to understand and use to our advantage.
Exactly. So keep breathing, keep learning, and keep exploring this fascinating world within.
And remember, if you're experiencing any breathing problems, don't hesitate to seek medical attention.
Early detection and treatment are key.
Thank you for joining us on this deep dive into the respiratory system.
It's been a pleasure exploring with you.
Stay curious, and until next time, breathe easy.